Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania. I'm Dr. K.K. Aggarwal. We are live on Facebook and YouTube, and it starts our official meeting. Thank you, Dr. Chong, Dr. Prakash, Dr. Russell, Dr. Jamal, Dr. Sanchita, Dr. Pillai, and Dr. Mary and Dr. Sajad. We will continue from we left last time, but before that, I will take up two important aspects before we start continuing what we left here last time. I'll request Dr. Chong and Dr. Pillai to chair this meeting. This meeting will be chaired by Dr. Chong and Dr. Pillai. I want to discuss one email I received, and based on that, so this is an email I have received. This is, my name is Tushar. I'm age 38. No previous medical history. Currently, I am in Congo, Africa. On 15th June, I developed extreme fatigue, body ache, loss of smell, and loss of taste. Our CMAAO guideline says loss of smell, loss of taste means 100% COVID. That means he developed COVID on 15th June. So by all practical purposes, after 10 days, that means 25th of June, he should have been negative for the virus, though the virus may still be detectable. So there are two terms, positivity and detectable. So on 25th onwards, the virus can remain detectable, but the report will be negative. But his test was done on 21st and reported on 27th. By the time it was reported, the virus was already non-replicable by all means. Now see here, PCR, RT-N1 CT value, RT-N1 CT value 25.32 and N2 CT value 25.84. CT is cyclic threshold, and if we take the average of the both, it is 25. That means his CT value was 25, which means after 25 cycles, the test became positive. Normally they do 40 cycles, and the cutoff varies from region to region, from laboratory to laboratory. So that means he had a CT value of 25th. In the meantime, during these 13 days, he was put on quarantine. And then on 26th of June, he was put on further isolation for a month, which was not required, because once you are negative, your test may remain detectable for some times. But he was put on further isolation for a month. Then 8th July, he was tested again, and the CT value was 34. That means CT value improved from 25 to 34, but it was interpreted as that the viral load is increasing, because they says from 25 it has become 35. Therefore, you have to go for another quarantine. It is just the reverse. If the CT value is increasing, it means you are detectable and the viral load is becoming less. He was put on heavy antibiotics again, hydroxychloroquine, azithromycin, and whatnot. Then on 7th of August, he was done a CT value again. And now they says your viral load is further increasing. CT value is 36 and 30, average 35. And now he's confused. He says for the last 3 months, he is without job. He is on isolation. What to do? So this is called misinterpretation of a RT-PCR value in countries like Africa. So therefore, a person whose CT value CT value is increasing. That means this person is virus detectable but non-infectious. He became all right within 10 days of illness, but he is being misinterpreted. He has been misinterpreted. That's what is happening. So I am making a paper which I will be presenting next time. I am making a paper which I will be presenting next time, and that will be on RT-PCR CT value interpretation and misinterpretations for a consensus of CMAAO group. That was why one thing which I wanted to share about the interpretation of CT value. Another thing which comes is that I want to give a presentation next time on a subject. I want to redefine COVID-19. So I will be presenting this next time, and I will invite views of everybody so that it becomes a new definition created by CMAAO. And the definition is, it is acute. So he says this is acute inflammatory. This is acute inflammatory. So I am calling it as immunoinflammatory. It is acute immunoinflammatory, manageable. I'm adding the word manageable because now you know how to manage it. Manageable viral illness with a post-viral phase. Because after 9 days of virus, up to 3 months, it has a post-viral phase. So I'm going to present my data next time on that to redefine. So I'm giving 1 week's time for all of us to think upon it. So I will be bringing 2 resolutions next time. One will be that CMAAO interpretation on RT-PCR CT value and misrepresentations and representations, so that every country we can come back with standard guidelines. And the second thing I will do is that I'm proposing a definition. This is acute. This is immunoinflammatory. That means it is the body is on slow fire. It is a immunoinflammatory. It is manageable today. So we can manage this inflammation. It is viral with a post-viral illness. That means after 9 days, when the virus becomes non-detectable, the illness can continue for 3 months. With this, I hand it over to Dr. Chong and Dr. Marthanda Pillai to continue discussions where we left last time. We discussed last time, I presented data of Asian countries. Dr. Pillai presented the data on countries related to Arabian countries. And then Dr. Chong presented the data of Singapore with other related China and other countries. And then Dr. Elvin talked about the Hong Kong. We are still left with other, because I still don't find people from Malaysia, because we wanted to know all those people, but you carry on that discussion, Dr. Chong and Dr. Pillai.
Good morning, President, and glad to take over the chair from you. We would like to ask our participants as to who is going to speak next. I believe the last time we wanted to hear from Bangladesh, was it right?
Bangladesh, yes, you can cover up. We wanted to cover this time the data of Thailand, Malaysia, Indonesia, those countries, because that was left, because there is nobody from there. You can carry on. And I would also like the chair to, because you raised one point on an email and you wanted to discuss various definitions of calculations, that also we will discuss today.
Yes. Calculations, I believe it was Elvin who raised the matter of the calculations. Is Elvin here today? Oh, I don't have Alvin here today. So
Doesn't matter. I'll still present the data after you finish, because that can be, the recording can be sent to him.
oh, okay. So as far as Singapore is concerned, we are reaching the tail end of our infections. We do not. We have completed the swabbing of all our foreign dormitories. We have about 330,000 migrant workers. We've completed the swabbing of all 330,000 as of yesterday. So we are looking at, I think quite a large number have gone back to work, about 260,000. Our community cases remain as 1 to 2 a day. So it's a very good figure. I'm not sure across the causeway what the situation is, but I hear from my MMA colleagues that they're very, very concerned about the issue of 2.4 illegal immigrants in Malaysia. So they have no clarity at all as to what is going on with the illegal immigrants in Malaysia. As far as Indonesia is concerned, I understand, I have not heard from my Indonesian colleagues at all. I think it is, but from what I understand from my patients who work in the World Bank, is that what's happening is that the testing is obviously inadequate for 200 million people. So what they've resorted to as a proxy to figure out how bad the situation is over there is to use luminosity. What does this mean? They actually send a satellite over the archipelago at night, and they measure the light patterns across the whole of Indonesia. And they compare it with base data from previous years. And from there, they can estimate what is the amount of COVID cases from satellite images. So this is what's happening in Indonesia. So I'm sorry to say, but I don't have first-hand information from my colleagues, have not been able to get hold of them. But this is what I understand from my patients in the World Bank. We also don't have our colleagues here today, so it's quite difficult to get any information from them at THASFA. Thank you.
Anything else? Then if there's anybody who wants to talk about the Asian perspective, then I'll take over the different formulas.
Just may I raise a point?
Yes, please.
Thank you. Good morning, everybody. This actually in Bangladesh. Actually, this last week actually I couldn't join actually because there was Eid day actually. Sorry for that. So today actually I'm just raising a point. In India, actually the number of cases are increasing actually by day, and in Bangladesh, the tests are limited. Near about 12,000 to 13,000 tests are done, and previously it reached per day near about 19,000, but somehow anyhow it has come down, and the cases are near about 24 to 25% positive in terms of those tested actually. So we cannot say actually how far the transmission has gone in community, and because the lack of tests and the people are losing probably their interest because actually the mostly the youngsters are getting the infection, but they are not going to be too seriously ill. What is the reason? Actually, the older people are getting whatever they are getting infected, more casualties are there. So probably the people are less interested and getting less interested in the tests, like what I feel. So may I just know actually what are the measures actually in India they are taking, so that we can just suggest the government also any extra measures they are taking in India to curb the spread of infection?
I come back again. Any extra efforts to reduce the infection?
Yeah.
Okay. There are only two models available in India. One model is Goa model. You don't allow the infection to enter the state. That's a Goa model. And the infection rate is very, very, very low. And the second model is Delhi and Bombay. Let it happen and let 22% people develop it. And now we have 22, the first wave is gone. So let it develop means that you prevent it as much as you can, but if you can't prevent it, it's okay. We have both the cases. Goa is not allowing the virus to enter in its territory. And in Delhi, you can't help it. The virus is all over. And if the virus is all over, the virus will only go when 22% of the society has got it. So in those areas, this is called as a model where the incidency, you go on positivity rate. If the positivity is more than 10%, if the positivity is more than 10%, you go with a strict precautions. And when the positivity is less than 5%, you let it happen. That's how the situation goes. So your positivity in your area has to be less than 5% or more than 10%. If the positivity of rate is more than 10%, then you are supposed to check every patient admitted in a hospital. You are supposed to check for a COVID-19 test. But if the positivity is less than 5%, it's okay. You can rely on the history. That's what the criteria is. So positivity rate will vary from district to district, area to area, state to state. So everything depends upon the positivity rate. Positivity is number of testing done and what is the positive rate for RT-PCR.
Okay, Mr. President, I would like to know how the Goa prevent the virus.
It's a small place, restricted place. You are not allowing people to enter. All travel is restricted. You are tested strongly, but that's not practical. You are only delaying the virus. That's not practical. Yeah, the space is high, the density is low. It's not possible. It's not practical. So the Goa model can only be restricted to a place which is different. But that Goa model is not practical according to me. According to me, answer is that restrict, prevent virus as much as possible. And if you can't, just manage it like any other acute manageable disease. The reason being, the model in Delhi and Bombay is personal lockdown. And in Goa is a state lockdown. That's the difference. So personal lockdown means you prevent yourself. In Goa, the government is making effort to prevent everybody, but how long can you? Our Home Minister has developed it. Our Amitabh Bachchan has developed it. Our Delhi Health Minister has developed it. So can you prevent everybody from developing it? Answer is no. You can't. You have to face the music. Someday or other, you will have to face the music.
But
prevent as long as you can. If you can't, let it happen. So personal lockdown is the personal lockdown versus a state lockdown are the two models. So the answer is personal lockdown. That means I take care of myself. These are the two models.
I don't know, in Pakistan, the people are not following any SOPs of to prevent the coronavirus. Nobody is wearing masks. Nobody is caring about the distance, or nobody is caring the handshaking and everything, in Pakistan. So how in India, the personal lockdown or personal follow SOPs, how do you think that the people are following SOPs in India?
What I'm saying is that a personal lockdown would mean that you wear a mask at home also. Because nobody is wearing a mask at home. So therefore, 23% of Delhi has already got infected. And the law is that if 25% of the population is infected, the first wave will go away. And now our positivity rate in Delhi is 7%. The day it come back to 5%, we say it's okay, let it remain like any other disease. The positivity rate in Delhi was 30%. It has come down to 7% because 23% population has already been infected. And that's because people are not following, they don't want to follow. They can't follow because at home there are one house, one room, 10 people staying. How can you follow a personal protection? You can't. With a high density, you cannot. Therefore, wherever there is a high density place, the herd immunity will come the first. So therefore,
So
I'm
what?
saying, so what? If you develop it, so what? Manage it like a acute manageable disease. And today we know it is possible to reduce the mortality to zero. Yes, you can reduce the mortality to zero. When zero means zero is not an absolute. Zero means that like any other acceptable mortality in any other illness. So zero is never an absolute, but in a medical science, like when you say that a cancer is cured, you say 5 years mortality is definition of a cure. So therefore, zero is not absolute, but yes, you can bring the mortality to zero. Means like any other illness.
So what about the prevalence in other districts or states?
It will vary.
Actually,
It
it
will
is
vary
it
from
is it.
district. There are 800 districts. Every district will behave differently. So you cannot compare a district from another district. Depends upon the strength of the people, number of people, their behavior, their culture, their intelligence. Things will change.
So the Indian policymaker is just denying the facts that the WHO is cautioning that you should not wait for this herd immunity. Is it going to be?
Nobody is believing on herd immunity. Herd immunity, we are not even believing. See, remember, let me explain like that. Let me explain that there are, at this moment, there are minimum 11 gangs working in India. These are called gangsters. So gang A, gang B, gang C, gang D. So these are gangs. So these are called viral mutations. Somebody says 11, somebody says 13. So suppose in Delhi, there is a gang C which enters. Okay, so third gang has entered Delhi. Now that gang will start multiplying from one to another. It is the same gang which is coming from, so this is called L gang. So suppose the L means lysine gang, the amino acid is L gang, that L will enter into one, then another, then another, then another. So the same virus is going from one person to another. Slowly, it will start attenuating like a vaccine policy. When you grow the same virus again and again, it loses its potency. So similarly, at this moment, when see the China gang virus which came first is now totally out of the whole world. The original China virus is not there anywhere. So it is the L gang, which is L virus, which is spreading. Now this L, suppose it enters in my body, so it has to go every time, it has to go to a person to replicate. It cannot replicate in the air. So it has to have a replication in a human being. So 1 to 2nd, 3rd, 4th, 5th, 6th, 7th. And every time it replicates in another body, it works like on the principle of an attenuated vaccine. The virus becomes less potent. So therefore, whenever a new virus comes, the mortality will be high in the first month. Second month, mortality will be lower. Third month, mortality will be further lower. Fourth month, mortality will be further lower. Now, this lowering of mortality will continue till another virus enters called M virus. Suppose S virus enters, and then will create a second wave. So the first wave is, that means there is a herd immunity of the first wave. Okay, then but the other population is still not immune. So you can call it as a herd immunity for that particular wave. That particular wave virus has become such a non-virulent that it doesn't matter to the people. And that's how we explain. So at this moment, the L virus is moving. Sanchita, what was, just you read out that L virus, that Chinese, that Science Daily paragraph, which we have the types of variants of virus, which you send it to me. Can you read out, take out that paper and read out how the various virus strains are, which are the viral strains which have disappeared and which are the viral strains which are still appearing. She will just read out, because we have prepared a document on that, what type of a viruses are moving. So therefore, when 23, that's what is happening in Pakistan, 30% people are positive. So their strain, now the new virus comes, that will again behave the same ways, high mortality, lower mortality, lower mortality, lower mortality, and then it will pass off. So ultimately, when we talk about herd immunity, you will go through at least 3 or 4 different types of strains of viruses to cover 67%. One virus cannot cover 67%. So one viral infection cannot get infect 67% because viral will lose its virulence. Did you find, Sanchita?
Mr. President, can I ask something?
Yes,
I'm
sir.
Dr.
Yes, sir.
Lochan from Nepal Medical Association.
Yes, sir.
So I think similar thing is happening in Nepal. You know, the first time when the virus came into Nepal, most of the cases were asymptomatic, and after the cases started decreasing, government decided to loosen up the lockdown. And again, now the number of infection is increasing, and that's for sure that when you loosen up the lockdown, we expect the infection to increase. But the second time when after the lockdown, most of the cases we are getting are symptomatic. So is it possible that is it possible because of the new virus, or is it because of the same virus or symptomatic patients uh, 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 spreading the infection to the vulnerable group who can be
So,
infected,
see,
I mean,
whenever,
symptomatic? What are
yes,
the possibilities?
Dr. Lochan, whenever you say, see, if the viral strain is the same, and if it causes a surge, it will have the same surge. But if you find now suddenly symptomatic viruses has come, that means there has been some mutation. We presume that a mutation has taken place. Now this symptomatic virus over a period of time again will become a symptomatic wave.
Sir, I have mailed it to you. I have
No.
mailed.
Yes, yes. So I'll read out that what is there.
May I say something, Aggarwal?
Yes, please,
Dr. Ashraf Nizami?
please, please.
Yeah. I want to say that as we have to live, as we used to say that we have to live pre-COVID era and post-COVID era. Unfortunately, we are now passing through the time when it is the present form that we are living within the COVID era. As you say, and you have conviction for that, that the individuals, they have to prevent or they have to safeguard. I believe multi-flange strategy is important and that is required. One is by the state, by the government, and certainly the individuals, which they have to follow the SOPs which are been generated, and these are been agreed upon by all of us, that the SOPs mean by the masking, hand wash, social distancing. These are the major, I think, components which has to be followed by the individuals. Having said that, the mutation, certainly the virus still, it is a very big question, and science is working on these lines, that the herd immunity, is it going to help it out or not? As you said, and I agree with that, that the herd immunity is not going to be the answer for all that. And I believe that the multi-flanked approach still it is required. As Pakistan, they have opened up the government. Everything is now going to be open 10th, and then it is on the 15th of September. But in my understanding, again, as colleague from Nepal has said, that as we are going to ease out the lockdown, and as you said, that if you go through the Australian and Victoria state has to go stage 4 over there now, complete curfew they are being compelled to impose. So still we have to find it out that the government, the society, and the individuals, they have to address this issue in a positive way, in a positive manner. And if we succeed as a government, as a society, to observe the SOPs, then certainly, to my understanding, that we can deal with this COVID-19 and reduce the mortality and the infection rate too. Thank you very much, Mr.
Totally
President.
agree, but I just want to carry on where I left. Currently, there are 6 strains of coronavirus. The original one, the L strain that appeared in Wuhan in December 2019. L is the name of the amino acid. So there is a particular sequencing where L is lysine or whatever leucine. The original one is the L strain that appeared in Wuhan in December 2019. Its first mutation occurred this is from the Science Daily. This is not my own. I have not done any work into it. This is Science Daily, which is undisputable. The first mutation came as S strain. That means the amino acid L changed to S strain appeared at the beginning of 2020. Since mid-January 2020, we have now strain V and G. That means LS, V, and G. To date, strain G is the most widespread. It is mutated further into strain GR and GH at the end of February 2020. Now, since strain D, strain G and its related strains GR and GH are by far the most widespread, representing 74% of all gene sequence. They present 4 mutations, 2 of which are able to change the sequence of the RNA polymerase and spike proteins of the virus. This characteristics probably facilitates the spread of the virus. That means with more and more mutation, virus becomes more contagious, but it will be less virulent. If we look at the coronavirus map, we can see that strains G and GR are the most frequent across Europe and Italy. According to available data, GH strain seems close to non-existence in Italy, while it occurs more frequently in France and Germany. This seems to confirm the effectiveness of last month's containment methods. In North America, the most widespread strain is GH, while in South America, it is GR. In Asia, that means we people, where the Wuhan L strain initially appeared, the spread of strains G, GH, and GR are increasing. So now I am working on the literature to find out what are the characteristics of G, what are the characteristics of GH, and what are the characteristics of GR. I'm still working with the scientists to find out how Asian, because now you can see different strains have a different type of a virus. So therefore, every time there is a mutation, the mortality will become less, but contagiousness will increase. Now in Nepal, unless we know it is G or GH or GR, we can't go further. So it is not that simple mathematics to calculate. We have to go into the science to find out what is happening in the epidemiology. Before I hand it over back to Dr. Chong, I just want to cover up because I received an email about definition.
The last question.
Give me 5 minutes, and then it will be open for discussion. Then it will be open for discussion. Then it will be open for discussion. So there were certain definitions which came. So let me explain those definitions. So there is a concept of death in symptomatic cases. Death in symptomatic cases, we normally take it as less than 1%. So death in symptomatic cases is less than 1%. So number of death multiplied by 100, you will get symptomatic cases in the society. At any given time, you take the number of deaths, multiply it by 100, then you would know what is the number of symptomatic cases in the society. Now this symptomatic cases, 1% is an average. It can be 2%, it can be 0.5%, it can be, say in Sri Lanka, it is lower. So accordingly, your country can calculate number of symptomatic cases at any given time in the country will be 100 multiplied by the symptomatic cases death number. Now cases after 7 days. How many cases? So 7 days is an average doubling time. So cases after doubling days, doubling time days. So whatever is your doubling rate, number today multiplied by that number doubling rate, the number of cases will be on that particular day so much. Suppose you have 1 lakh cases today, your doubling rate is 20. The cases will become 2 lakhs after that particular day. Now, how many, suppose you say, how many serious patients are admitted in a hospital? So death rate in the hospital multiplied by 7% is the death in the hospital. So you can calculate how many patients will be there in a particular country as far as serious patients are concerned. Uske saath mein. So what is the lockdown effect? What do you expect as a lockdown effect? That lockdown effect should say number of cases reduced after 5 days. Suppose you say there were 1 lakh cases, we created a lockdown, it became 50,000 after 5 days. So number of cases reduced after 5 days is called lockdown effect. Then lockdown effect in reduction of deaths. What after 14th day of lockdown, whatever is the percentage of deaths which reduce is the lockdown effect. Because the first 14 days deaths will be deaths because of patients before the lockdown. Requirement of ventilators after 9 days. So you say today 100 patients are admitted. You will say 3 additional after 9 days, 3 ventilators will be required. You can calculate that. Requirement of oxygen after 7 days. So we know that number of cases detected today, out of them 7% of them will require oxygen after 7 days. Number of people, suppose number of cases today, you can calculate how many of them will require a home care, 90%. Requirement of ventilators, you can say 1 to 3% after 7 days. Then case fatality rate. Case fatality rate is number of deaths today divided by number of RT-PCR positive cases on that day. Total number of deaths today versus number of RT-PCR positive cases on that day. But there is also a calculated actual death rate, case fatality rate, which will tell you total number of deaths today divided by total number of positive cases 14 days back, because that represents the true number. Then infection fatality rate. Infection fatality rate is total number of deaths as on today divided by total number of cases as on today, which can only be calculated, which cannot be estimated. That is number of cases today multiplied by 10 to 30 depending upon the country. Number of reported deaths is equal to number of confirmed death, number of number of deaths is equal to number of confirmed deaths multiplied by 2. Because for every one death will not be RT-PCR positive. Number of unreported or untested cases will be 10 to 30 depending upon the country's positivity rate of the antibodies. Number of asymptomatic cases, for every 6 symptomatic cases, there will be 200 asymptomatic cases. Number of oxygen requirement on that day in the hospital at 6 a.m. is equal to number of cases detected to have hypoxia on 6-minute walk test. These are the calculations by which you calculate, you estimate and calculate what is going to happen. So for everything, there are calculations available for a country, for a state, and for other things. I'm further evaluating on this and make formulas more comprehensive. I hand it over to the chair to continue the discussions.
Thank you very much, President, for your explanation of all the figures for the epidemiology figures. Alvin raised some questions. Alvin, do you have any questions after presentation by President?
Well, thank you very much, Mr. President, and also thank you, Chairman. And I just thank the President for your explanation on the definitions of analyzing COVID-19. So I am very interested in the formulas that you had also posted in the myths and also the facts of coronavirus. And, you know, at the bottom of your presentation every time of the reports of the your email, I think that's very important. Those about 8 or 9 formulas in calculating all those different parameters. Just to know whether we could also discuss those things. It's quite useful, I think.
I got a call from a couple of hospitals from UK last month, and they said that we use these formulas for their estimates, and they were it helped them a lot in deciding the care in their hospitals in UK based on these formulas.
President, these formulas were derived from local data
No,
in India?
these are all data, international data. There is a reference to every calculation.
Got it. Thank you.
I only summarize them, and I have been using these data. See, every data represents one particular observation in some country.
So got it. Understand. So all this came from extensive reading and of several sources and so on. Thank you.
I started reading, I started writing and comparing on 7th of January from till today, 7th of January to 8th of August. On a daily basis, I'm writing about CMAAO role in COVID-19.
Thank you, President, for really pushing CMAAO to the forefront.
Mr. Chair, Mr.
Yes.
Chair, may I raise a question?
Yes,
This actually, in Bangladesh, a controversial actually government order has created chaos here, actually, regarding the duties of the doctors and the healthcare professionals. This is actually, previously we are practicing here 7 days work and 14 days quarantine and 7 days in the home. That 4 weeks to turn. And then after 4 days, 7 days in home, he comes back to the work again for 7 days. So that was actually practiced from the beginning. Now the government wants to change it. So that has created confusion here. So what they have done, it's 14 days work and 14 days quarantine, something like that, and no home. So can I get some sort of suggestion? India, Pakistan, like that. So, or even Singapore. I think you have very less cases. So there should be a different here condition. But in Pakistan, Nepal, or India, if anything can be suggested from there, so that we have a meeting tomorrow, so that we can come to a consensus.
Anybody else who wants to speak? I will tell them after that.
President, maybe this would be important for CMAAO to make a statement for Dr. Jamal for his Bangladesh government or ministry to take note.
So let me say.
I think, Mr. Chairman, can I say?
Yes, please.
Okay. I think we have to follow the WHO, as the WHO says, the 14 days working and 14 days quarantine. After when you are working at the working with the corona patient, you have to have a 14 days off in quarantine. So this is a WHO, and we are also following in field isolation center in Pakistan and in different hospitals. The doctors are doing the same.
What about the 14 days work actually? Can they work actually with this PPE or gown and others in the
humid
conditions?
This is absolutely the responsibility of the government to provide all the logistic, including the PPE, so that the doctor can be prevented properly.
I have not raised that question. I have raised that the doctors putting on these gown. That gown actually is it's this is a humid condition, and the gown is hot, and your wards are not all are air conditioned, not at all. So all these things make it uncomfortable for a doctor to continue his work for continuous 14 days. So we started 7 days actually beginning, as China started the model. We followed that China model. So after that, actually, we came to know that after 7 days work, if someone goes to quarantine and if he tests after 5 days, and if he is tested negative, he can go to the home. And you have to allow him to go to the home also, because in those days of work and quarantine, he has to keep himself somewhere arranged by the government, that he can stay out of his home. So we have practiced that till now.
But if the doctor individually have the the room facilities
He
in
can, he
their
can, he can, he can.
so
That's
then
about that.
he can go to home also and
Yes,
isolate
he can.
themselves for 14 days at home.
So, but what about the 14 days work?
Okay, the 14 days ward is, in isolation. If the sorry, in ICU or in HDU, you have the ACs. So
Okay.
in that condition, you have to wear the gown of 70 or 65 GSM, which is very thick. But in the ward, or if the ordinary other wards or in the OPD, you can just wear the 45 GSM gown, which is slightly light, and it can be wearable. So you can manage this with the condition of your ward or condition of the ICU or HDU.
So you're not
Can
allowing
I,
him to.
can
You're
I
not.
take,
You do not have the. You don't have the arrangement from the
no,
government. Those who doesn't have that arrangement in their home to keep himself isolated or quarantined. If somebody doesn't have it,
can
so
I make a statement?
Yes.
Can I make a statement? I think the WHO also WHO advisory has to be based on science, and the WMA CMAAO can give their guidelines to WHO if we feel that if we differ into it. So I would like to make a committee of Dr. Chong, Elvin, myself, and Dr. Sajjad from Pakistan. Let's work on it. Let's come back with a statement. Why? I'll give you some basis behind that. Why this meeting is important. The reason being, I'm reading out a protocol to be followed for pre and post flight COVID-19 in testing for operational crew. Okay, they are also traveling, they are also at the same risk as that of a doctors. In India, Air India, on the directions of Government of India, shall be operating special flights to foreign domestic destinations for transportation of standard passengers. This is pre-flight COVID-19 testing. That means all the doctors who are joining duty, their pool testing can be done. Suppose there are 10 doctors on duty joining on Monday. You can do their pre-flight pooled COVID-19 testing. Pool testing by Singapore can be done on 64 people. Kerala says 20 people. ICMR says 5 people. So if you are a low risk category, pool testing can be done of 20 doctors at a time. The crew, I'm only changing the word. The doctors will be required to visit the designated venue for COVID-19 testing for the purpose of giving sample up to 5 days prior to the duty date. The doctors are required to carry with them their Aadhaar card, AEP, and other for the purpose of identification. That means 5 days before your duty, you can go for a pre-duty COVID-19 pooled testing with RT-PCR, which I will come back. Then the post-flight COVID-19 testing, that means after your duty of 1 day, 2 days, 7 days, 14 days, on return, the doctors will undergo the COVID-19 testing at the pre-designed collection point, after which you will be accommodated in a hotel with a full board till the test results are available. If the test is negative, you shall be transported to your residence. That means this is what the policy for a airport flight is. The last COVID test will be conducted on 5th day of arrival. That means once you have shifted to your home, after 5 days, another testing will be done. And if that test is showing no symptoms, then you can come back to the further duty. That means it is 1 week of, they are not talking about 14 plus 14. They are talking about 7 days at home after your duty. So if we use this, and let's take other international flight criteria, mix it up with the doctors, then we do it. Now here I want to spend 2 minutes in making you understand what is RT-PCR. RT-PCR is detecting antigen. RT-PCR is detecting antigen. The antigens can be ORF antigen, RDRP antigen, E antigen, N antigen, S antigen. Now the criteria is that E antigen, which is envelope antigen, has to be positive because all coronaviruses will have the same E antigen. So if your E antigen is negative, you have no corona. E antigen tells you that you are corona. So therefore, in a RT-PCR test, you do a E antigen positivity. And then different kits are available who are using ORF, N, S, or RDRP, out of which various governments says different tests can be, if you are using E and RDRP, then you will be, your sensitivity will be maybe say 60%. If you are using ORF and RDRP, your sensitivity may be higher. If you are using ORF, RDRP, and N, your sensitivity will be further higher. Now, to make more margins, most of the labs are not doing multiple antigens. They are checking only one antigen. So if for doctors, we create a policy that minimum 2 antigen tests should be done or 3 antigen tests should be done, then your chances of false negativity will be lowest. As on today, RT-PCR is accepted as 30% false negativity is accepted. But we can reduce it to 80%, 90% by giving our recommendations that for a medical fraternity, you check for all 3 antigens. If anyone is positive, you are positive. With that, you can reduce your quarantine at home. So therefore, CMAAO can come back with the guidelines that you work for 7 days, for 7 days duty, 7 days off. During that off, follow the following guidelines. And so you repeat your test on day 1 and day 7. And if you are negative, come back to the duty. So that is as on today, it is 7 plus 7 plus 7. That means 7 days duty, 7 days hotel, 7 days residence. So whatever you follow, CMAAO can come back with our own scientific guidelines and send it to the WHO. So I'm only creating a group to go into the science behind that. We should not follow just because there has to be a science. Why WHO is saying 14 plus 14? There has to be a reason. If we don't agree with that reason, we can write to the CMAAO. So I would like Dr. Chong, myself, Dr. Sajjad, and Dr. Chan. Let's take 1 week or 2 weeks to come out with the guidelines on this. That can be CMAAO guidelines. Whether WHO agrees or not is a separate issue. Back to the chair.
Thank you, President. And I hope Dr. Jamal that we have kind of answered your questions, right? And you will have a good negotiation with your ministry tomorrow.
But very confusing, I think, very confusing, because Dr. Sajjad, very confusing.
Can I say something?
No, this is very, actually, it has created very hue and cry in Bangladesh. Actually, you know, Bangladesh Medical Association already reacted on this here, on this order. So I must know, actually, I didn't see, actually. I didn't see Dr. Sajjad was telling me about the WHO recommendations. I have not seen so far. There's 14 days work and 14 days quarantine. That I don't know from where I haven't seen. So
I think
I am also in the technical committee. I am also working with the technical committee here, the national level, and we have also seen so many papers. I don't know, Dr. Sajjad, can you just tell me when it was published, this WHO guideline, 14 days work and 14 days quarantine?
I think practically it's very difficult to ask people to work for 14 days straight. Basically because you and I know that fatigue will set in. And when fatigue set in, we have cases in Singapore where fatigue set in, the doctor puts on the full PPE, goes into the isolation room and comes out and realizes that he or she forgot to put a mask on. So we have situations like this, and I think asking a doctor to work 14 days straight is not a very sensible recommendation. And I have not seen such a recommendation from WHO. So I think, Dr. Jamal, before we go and look up all these things, you just go and tell your your powers that be in your country that it is not practical to work beyond 7 days because there's fatigue.
Yes.
And definitely you have to let the doctors go home to their families, because otherwise mental problems will occur. I think it's straightforward.
Yes.
It's
Yes.
straightforward.
Mr. Chairman, can I say something?
Yes,
For,
please.
Mr.
Yes.
Chaudhary?
Yes, Professor Ashraf.
Yes.
I want to say that as we work very closely with our Chinese colleagues, and they visited Pakistan, and we were of the opinion with them that duty hours should be reduced. If the medical fraternity over here in Bangladesh, they can afford it, it should not be more than 4 hours. So you can reduce the viral load over the professionals, and certainly the SOPs, if as Mr. Chairman, you said very rightly, it is easy to say that 14 days or 7 days were the facilities what Bangladesh, Pakistan or India have. But we have to speak about, if it is possible, I suggest that Mr. Chaudhary can talk to his authorities that 4 hours are more than enough, and maximum 5 to 6, because we have seen people are working for 8 hours and more. That is the viral load which is creating a problem.
Yes.
I will make a resolution. Let's vote for that resolution. And then Dr. Chong can create a resolution which myself and Dr. Chong will sign. And Dr. Chong will draft that resolution. And that can be passed on to the Bangladesh Medical Association. A copy of that going to all the medical associations, and they can submit it to their respective governments.
That will be good. That will be good.
In a meeting held on date 8th of August 2020, it was discussed and resolved that doctors' duty hours for a COVID duty should not be more than 7 days at a stretch, and should be less than 8 hours in a day, preferably 4 hours. If everybody agrees, then I can ask Dr. Chong to make a statement.
Yes, everybody, yes. I think it's practical.
And after 7 days, please, after 7 days of work, the quarantine and others.
Dr. Jamal Chaudhary, because after 7 days, we will work out, because we have created a committee, let the committee come back.
Okay.
What should happen after 7 days? But at least this much we can resolve, because that will help your country. This much we can resolve. That duty structure should be less than 7 days, and duty hours should be less than 8 hours, preferably 4 hours.
What is practiced? What is practiced in India? Can you just tell me?
777.
777. That's fine. That's fine.
Duty hours has to be minimum 8 hours. 4 hours will be very impracticable. Getting that much of manpower will be difficult.
Actually, manpower will be the problem. Same is in Pakistan and in Asia countries, human resources. So the 8 hours a day, is good, and according to their situation in the country, they can manage. I agree with the 7 days duty and 7 day off. And I just endorsed Dr. Chand that the doctors are allowed to go to home so that they feel comfortable, and with all the SOPs they can isolate at home, and then they will feel comfortable, so they can be able, and he can be able to work for more 7 days. So they should allow to go home, I think. Dr. Jamal can demand this from the government.
That point of what happens after 7 days, for that you are a part of that committee.
Okay, fine.
7 days to build up that. Let's not be in a hurry. At this moment, we have a temporary resolution, less than 7 days, less than 8 hours. That's all.
Okay, fine.
We are putting it less than 8 hours. Let the country decide what that 8 hours are. We cannot write at least 8 hours. If you say at least 8 hours means it can be more than that.
No, maximum.
More than that. We say less than 8 hours. Let them
decide.
Less than 8 hours or 0 hour, let them decide. So I would request now Dr. Chong and Dr. Pillai to sum up.
Excuse me, can I ask last question, please?
Yes, please.
I'm from Nepal. I put just the last question.
Sure. Carry on.
So So the two questions is in Nepal, you know, the doctors, healthcare workers are getting infected day by day, and what are the things that we can do to prevent the infection between healthcare workers? That will be one question, and another one is regarding the test guidelines. You know, WHO also has, made a confusion that is it not necessary for the asymptomatic to go for a test, or is it okay to discharge patient after 14 days if they are asymptomatic for another 3 days, that the RT-PCR is not required before discharging? We don't require RT-PCR, something like that. Is it so? Test guidelines regarding RT-PCR.
With the permission of the chair,
Yes, please.
virus is non-replicable after 10th day. There are n number of studies available. After 10 days, virus can be detectable for 40 days, but not positive. So there are two terms, positive report and detectable report. After 10 days, the policies are after 10 days, the virus is non-replicable. Accordingly, your countries can make your policies. There is no need for testing a positive patient after 10 days. Even if the patient has a post-viral illness, the virus is non-transmissible. That means if a patient continues to have fever on 30th day and RT-PCR is positive, does not mean the patient is infectious. So for all practical purposes, 10th day, the patient can go out because you want to give them a margin. Therefore, everybody accept it as 14th day. After 14th day, irrespective of symptoms, a patient can join back the duty, and irrespective whether the test is detectable or not. This is what I showed in the initial case, that in a patient after 14 days, if you repeat RT-PCR with the same kit, same lab, the CT value will become very high.
Mr. President and Mr. Chairman, before the end of the meeting, I'd like to raise two issues for your solidarity, perhaps. Now, first of all, in Hong Kong, the medical profession is being attacked and smeared by many people. Well, that is because of some political reason, because of the political stand of some of the leaders, and also even the experts, the infectious disease specialists, and their stand not just being questioned by some of the people, they are being attacked and smeared. And I wonder if that happened to other countries or not. But in Hong Kong, this is quite a disturbance to the morale of the doctors in this COVID-19 pandemic. And in fact, as I had told you last week, there's the third wave in Hong Kong. It's quite a difficult situation. And so we need somehow to have a united workforce and cooperation with the population. But then because some of our leaders' opinions are opposite to the government's opinion, all right? And then the government had in fact already invited the rescue teams from mainland China to help out in Hong Kong without pre-arrangement of any registration processes, etc. So that's why there's some noises and voices and objections from the professions. So this is the first point. And having said that, that is a fact already, that medical technologists and also medical teams, they are coming to Hong Kong to help Hong Kong to do an en masse population screening, like what Singapore is doing, but even a bigger scale now for all the 8 million Hong Kong people. And then yet there's no concerted efforts to, adequate workforce to contact tracing. So that makes it quite meaningless, even though you found those so-called silent cases in the population. If you don't have the manpower to trace those things, then it might create more panic, in fact. So, and also then they will just build some makeshift temporary a mobile hospital again in some places in Hong Kong. So this is the situation first in Hong Kong. And the second thing I would like to draw your attention is about Korea, because we all read from the news that in fact the Korean doctors are protesting, they are demonstrating, they are objecting the government to train more doctors. They said they are already very jeopardized in their daily living, not enough income, not enough doctors. Now, in contrast to our discussions just now, we are worried about manpower in air crew as well as in doctors. We don't want the doctors to be fatigued or overworked, so we need rest. But in Korea, they had just the opposite situation. Perhaps their pandemic have been quite controlled already and not in such emergency situation like us. But then I think the government, of course, would think that training more doctors in the long term is good for the population, so that even the rural places could have enough doctors. So I just wonder, would we have to get in touch with our Korean colleagues, what's happening there, and whether we could have some moral support there, or in fact, we don't need to, because different countries, in fact, have different situation in reality. But I just remember, say, Dr. Cho, last time he told us he's in Serbia or in somewhere. I forgot exactly. It's in, I mean, do we have to show some concern or care for them, for the Korean doctors? Thank you.
Well, President Dr. KK, I probably heard Dr. Ashraf. I just wanted to update you what's happening in Victoria or Melbourne in Australia. As Dr. Ashraf just said, it's a funny situation because you have Victoria alone having this outbreak, which I think last time I mentioned. So we've had, and this is what I was looking at Dr. KK's calculations. So exactly they're doing all, what has happened was there was 2 months ago a security outbreak. I mean, the quarantine, there was the security people, somehow that is a judicial inquiry into that. But that has led to a string of the second wave, but it's gone out of control where we were getting 400, 500, 600 a day. Of course, they're doing 40,000, 45,000 checking and so forth. So it has gone completely out. And so stage 3 was moved 4 days ago to stage 4. Never before in the country has this, ever had a curfew and all the same things happening. But together with this, there's also been an infection an epidemic into the aged care. And that has been contributing to an increased number of deaths. We have about 10 to 12, 13 deaths. We probably reached about 150. Previously, it was very low. So that has led to, and I'm listening to Alvin's third, we're talking of the second, they're already talking of the third. And so now we have 6 weeks of this, 1 week is almost less than a week is over. And so there's a complete shutdown. On the other side, we have 4 other states who have virtually no virus. And you have New South Wales, which is getting a flow over. With all the strictness, they still have got people, some of the infection has gone through, and they're having, about 25, 20, like that. But it's still contact. But here, it's gone fairly out of control in terms of contact tracing. They have about 4,000 people doing this. The army has come out and very strict, trying to bring this down and so forth. Somewhere something went wrong, but anyhow, that's down the track for them to inquiries going on.
Thank you very much.
Yeah. Thank you.
Thank you very much. I note with
Dr. Pillai here, just a comment
Yes.
by me. I had some connectivity problem, so I couldn't hear the whole deliberation, but whatever I heard, it's a very quality discussion and a lot of scientific material has been shared by KK. And even fixing of quarantine time, working hours, and the rest which suit the CMAAO countries has to be worked out. And definitely the committee, which has informed, will come out with recommendations. And thank you.
Thank you very much. And because our time is running short, we are actually 15 minutes over time. Yes.
Mr. Chairman, just I want to go this solidarity with Alvin. I feel that CMAAO should come forward to address the issues which we are facing in the CMAAO countries. Thank you very much, Mr. Chairman.
Thank you. I think at the end of the day, we watch with some dismay as what's happened in Hong Kong and what's happening in Victoria with the second wave or the third wave, whatever definition you want. And I think in particular, Hong Kong, I'm very concerned because of the aged population there. I mean, a spread in the aged population would be devastating. And the numbers in Victoria are also massive. My son is working in the Monash Hospital, so I know a little bit about that as well. So I hear with some dismay about what's happening in our two member countries, and I hope that the situation will improve. As for today, I've quickly written a resolution for Dr. Jamal for Bangladesh. As worded in a CMAAO meeting today on the 8th of August 2020, it was resolved unanimously that COVID duties for medical staff should not exceed 7 days at a stretch, and the daily shift should not exceed 8 hours. So I'll send this to President, and we'll draft it out and sign it and forward it to Dr. Jamal for his negotiations with Bangladesh authorities tomorrow. Thank you again, President, for the very enlightening figures that you came up with from all your reading from January till now. Very, very enlightening and very helpful to all of us as we cope with the various situations. I think the subcommittee will look at further matters with regards to, the working hours and so on. And also, I think we will reach out to Korea. We'll try to reach out to Korea to see whether they need any kind of assistance from CMAAO. Nevertheless, the COVID situation in Asia is still far from clear. I think we have second, third waves and so on. Singapore, we're just finishing up with our first big wave. So, it's anybody's guess. And the virus continues to come in. Even in China, it came in on the packaging of frozen foods. In Melbourne, it was because of quarantine procedures that were not followed. And I believe in Hong Kong, it was because of some exemptions of certain groups of people who were not tested. And so this virus is honestly really, really formidable. And just when you think you've got everything sorted out, there's a little loophole and it just come true. So I think we live in very dangerous and very difficult times, and there are a lot of difficulties everywhere, but I think we all have to hang on in there. And I think these weekly Zoom meetings are very, very helpful for all of us to keep our morale and to keep all the information up to date. So thank you very much. Just one last thing for President. President,
I just want to know who is Hagee. John Hagee, somebody has joined. I can't recognize him. Can you introduce yourself? John Hagee.
From Israel Medical Association.
Good.
Excellent.
Israel Medical.
Excellent.
Good. Congratulations on joining us here. Show us your face. Israel is doing a wonderful job. Next time we will like to listen to what you people are doing in terms of new innovations. You are trying to create a sniffing the dog computer to sniff the virus out of the breath of a person.
Wow.
Is he the new chairman of the WMA or not?
No,
not he. He represents Israel. The new WMA president is from Israel.
Brazil.
He's not.
No. So, Chong, you wanted to say something? Yes.
Just President, for our CME purposes, is it possible for IMA to issue a CME certificate for these Zoom meetings?
We will give it. Draft a letter. You draft a letter, we'll give it to you.
Okay, thank you very much. Yes.
And
hello, Zion.
Just want
Dr.
to sum up.
Hagee.
Yes, Dr. Hagee, can we see you? Yes, go ahead.
Yeah, hi.
Hi, everybody.
Hello.
How is your new invention? Last invention you were creating, you and your wife were creating some inventions. I think
Before we finish, Dr. KK, I want to thank our president. He, on behalf of the UNESCO's international program, he presented, well received. 58 countries took part in that, and I think some of you were there. It was a very good. We had a presentation on the COVID, which was very well accepted. I want to place on record this on behalf of the UNESCO Chairs International Program, which spans over 58 countries, 250 centers. So thank you very much.
Mr. Chairman and Mr. President, KK, can I just suggest kindly please be restricted to your time. Actually, me, myself, and somebody else want to go to hospitals or any other work. So can it be possible that you just restrict your time to 1 hour, whatever you have?
Absolutely, absolutely. Yes. The meetings normally close at 1 hour, but sometimes there are discussions which are so important at that particular moment. In somehow, if the discussion continues, those can be excused exactly.
Yes, please. Yes, please. Yeah.
Okay, thank you very much.
Thank you.
That will be taken on record that anybody can leave exactly at 10:30, but sometimes the discussion is so much. Even today, 10:30, I had a meeting. I have to postpone that because the discussion was very interesting. So I request Dr. Chan, Elvin, to prepare those resolutions which you want for Korea, Hong Kong, and other countries. Whatever you suggested, create a draft of a resolution, send it to Dr. Chong. Both of you send it to me. I'll sign it. We send it to those respective countries. And I will make, just now, I will give a call to the Korean Medical Association and ask them what do they want. So I will ask the Korean fellow and discuss with them what do they want. That's all for today. We will be back next week.
Mr. President, just a minute, just if you allow me. Just I will request you that the issue in the Britain, kindly also consider that issue, that it is the racism over there. And if you consider it, kindly do it too. Thank you.
Kindly, Dr. Professor Ashraf Nizami, kindly draft a resolution and you make a draft of that resolution also. Send it to Dr. Chong and then we will issue all those resolutions today.
Thank you. Thank you very much.
Thank you.
Anybody can bring a resolution, draft a resolution, we discuss here, we pass it and we issue it.
That's great.
Thank
Mary
you.
wants to say something.
Right.
Mary?
Thank you.
Thank you very much for every time. Will you kindly share the text which Dr. KK presented? Please post it on WhatsApp.
Yes, I will send it to the WhatsApp group. Thank you, everybody. See you next week.
Thank you very much.
Thank you. Thank you. Bye-bye.
Thank you. Thank you. Bye-bye.